Hi everyone, and thank you for joining us on this Tuesday. Is another webinar of the Pulmonary Circulation Assembly Journal Club working group. On behalf of my co-editors, Marianne Sharifi Sanjani, Jurjan Armand, Maidah Yaqoob, Dominic Rotto, and also our new co-editor, Dr. Akshay Kohli. Thank you for joining us. Today is one of our most important webinars that we do every year. Is called the Best of ATS Clinical, where we highlight what we consider some of the most important abstracts that were presented during ATS related to pulmonary vascular disease. Uh, the abstracts we choose are mostly selected, giving preference to early career scientists, trainees, and young investigators. We have a great panelist with me today. I have Dr. Maidah Yaqoob from Cedars Sinai. I have Dr. Sandeep Sahay from Houston Methodist, and also Dr. Adriano Tonelli from Cleveland Clinic. We have 4 abstracts to discuss today. Um, After the presentation of each abstract, we will have time for questions. So any comments or questions that you have, please write them down on the chat box and we will do our best to go through them. And with that, let me introduce to our first presenter. We have Dr. Priyanka Sridhar from Mount Sinai. Priyanka, if you could upload your slides.
Good afternoon, everyone. I'm Priyanka Sridhar. I'm a second year pulmonary and critical care medicine fellow at Mount Sinai, Morningside and West. I'm very honored to be here today. Thank you very much. And under the mentorship of Dr. Steiger, I had the opportunity to present our abstract on association of time to anticoagulation with right ventricular function on outpatient follow-up among patients with pulmonary embolism managed by our PERT team at ATS. Again, I'm very honored to be able to share and discuss this abstract here today. So without further ado, PERT at our institution, like at other places, began around 2018, and it consists of a multidisciplinary team consisting of an on-call pulmonologist, an intensivist, a cardiothoracic surgeon, a cardiologist, and an interventional radiologist. And usually at the discretion of the primary attending taking care of a patient with PE, PERT gets activated. And the general criteria for PERT activation within our system is, of course, a diagnosis of acute PE at the time of admission. And usually we manage patients in the PERT team who have intermediate high risk stratification of PE based on the European Society of Cardiology 2019 guidelines. But in some cases, at again the discretion of the primary team, we might activate PERT for a lower risk PE patient if we feel the patient meets certain clinical criteria for activation. And for each PERT consult, the management is based on an interdisciplinary discussion among the different specialties, and then we move forward with a treatment plan. So in that vein, the rationale for doing this study was interesting because when we talk about time is tissue, that's a very well-established concept in diseases like ischemic stroke or myocardial infarction. But we don't really have a specific time to intervention, whether that intervention is starting anticoagulation or initiating advanced reperfusion therapies in patients with PE. That time to intervention is not something that's very well established, which is why we were motivated with this study to look at an association between time to anticoagulation in our cohort. And the outcome we chose to look at was echocardiographic parameters of right ventricular function on outpatient follow-up of patients with PE who are managed by our PERT team. So we have our PERT database, and we retrospectively looked at that database. This database consists of patients who are managed by PERT within our 3 teaching hospitals in the Mount Sinai Health System. And we looked at 3 years from 2021 to 2023. We defined time to anticoagulation as the time from diagnosis of the PE by a CTA to the time when systemic anticoagulation was initiated in the patient. And then we performed propensity score matched analysis on our cohort. And we conducted regression models on this propensity matched sample to look at the association between time to anticoagulation and echo parameters. So looking at some of the demographic and clinical characteristics of the patients with PE in our study, there were 123 people who were included in this study. The median age in our cohort was 64 years, of which 57% were male and 43% were female. And the most common risk factor for PE in our cohort was active malignancy among 11.4% of the people, followed by active smoking status in 10.6%, and the remaining population had other risk factors, including surgery, recent travel, prolonged immobility, family history, or predisposing medications. The median PESI score in our sample was 87. The median CPES, which is the composite pulmonary embolism shock score, was 3. And the ESC risk group stratification, the most common risk group was the intermediate high risk category, with about 62% of the people belonging to this group, followed by 20% in the intermediate low risk, 17% in the high risk, and we had one patient who was in the low risk group of PE. Looking at the characteristics of the PE now, 68% of the people had a PE in one of the lobar branches, and 49% of the people had a main pulmonary artery PE. And about 88% of the people had findings of right ventricular strain on their CAT scan. And this table just talks about the proportion of people who had associated deep vein thrombosis in their lower extremities and the relevant lab parameters. So looking at some of the treatment and outcome of patients within our study, so all the people, all 123, 100% of our sample received systemic anticoagulation, of which 81% received unfractionated heparin and 19% received low molecular weight heparin or Lovenox. Among people who received advanced reperfusion therapies, the most common was catheter-directed embolectomy in 17% of the population, followed by catheter-directed thrombolysis and surgical embolectomy in about 9% of the people, and 7.3% received systemic thrombolysis. And some of the relevant outcomes that you can see on the table on the right of your screen, one patient within our cohort died within their admission, and the reason of death was from a PE itself. 3 people, that's about 2.4% of our cohort, died by 30 days. We had 2.4%, again, 3 people who had readmission because of thrombosis, and 1 person was readmitted from bleeding complications. So in our cohort, the median time to anticoagulation was about 2 hours. So what we did was, looking at our sample, we did propensity scored matching, where we looked at parameters such as age, BMI, PESI score, the ESC risk group, receipt of advanced reperfusion therapy, and their composite PE shock score. And we considered all these parameters, and we did propensity score matching. And then we divided our cohort into 4 groups, or quartiles of time based on their time to anticoagulation, or TTAC. So based on that, the patients in the first quartile of TTAC received anticoagulation within an hour. That was around less than 57 minutes. And patients in the fourth group, or the fourth quartile, received their anticoagulation after 4 hours. So when we did this, when we classified these patients according to their time to anticoagulation, we then constructed forest plots where we looked at 2 important outcomes. The first one was looking at the marginal means of change in echo parameters on follow-up among patients who received anticoagulation in the first quartile and among those who received anticoagulation in the fourth quartile. So what this basically means is, for each quartile, each patient in each quartile, we looked at each of the echocardiographic parameters mentioned in this table, and we compared those parameters for each patient in each quartile at so their baseline echo, and then the echo on follow-up. Now, in our cohort, patients received follow-up echoes post-discharge at different time intervals, some at 1 month, some at 2 months, some at 6 months, but the median follow-up echo for our cohort was about 26 weeks. So we compared each parameter at baseline and then at 27 weeks, and we calculated the difference between these two time periods. And then for each quartile, we calculated the mean of the difference between the baseline and the follow-up for all the patients in a particular quartile. And then we compared this mean difference across quartiles. So marginal means of change is basically this comparison of the mean difference in the parameters between different quartiles. And we focused on the first and the fourth quartile. Again, first quartile meaning being patients who received anticoagulation within an hour of their diagnosis of PE, and fourth quartile are patients who received anticoagulation beyond 4 hours of their diagnosis of PE. So when we did this analysis, what we found was that patients in the first quartile had a greater improvement in two specific RV parameters on follow-up. That was the tricuspid regurgitation velocity and their pulmonary artery systolic pressure. So in this sense, a negative number here means a greater reduction in that particular parameter, which means a greater improvement in that particular parameter. So patients in the first quartile who received earlier anticoagulation had a greater reduction in their tricuspid regurgitation velocity and their pulmonary artery systolic pressure, as opposed to patients who received anticoagulation later. Another forest plot that we constructed was looking at the normalization of these echo parameters. So again, for each quartile, we calculated the proportion of patients who had normalization in their parameters, and we calculated what the odds were for those people to have normalization of these parameters. And then we calculated the ratio of the odds for the normalization of parameters between the first quartile and the fourth quartile. So understandably, an odds ratio, therefore, of greater than 1 would mean that patients in the first quartile had a greater improvement or normalization of those specific parameters as compared to patients in the fourth quartile. So similarly, we found that for the tricuspid regurgitation velocity and the pulmonary artery systolic pressure, there was patients in the first quartile who received earlier anticoagulation had greater normalization of these two specific echo parameters compared to patients in the fourth quartile who received later anticoagulation. So these were the two main relevant findings of our study. And I now want to move this conversation forward to discuss what is the relevance of these findings in the post-PE realm of things. So when it comes to which anticoagulation and when to initiate it, both the original CHEST 2012 guidelines and the ESC guidelines from 2019, they recommend actually initiating anticoagulation with Lovenox or fondaparinux as opposed to unfractionated heparin. The idea being lower risk of bleeding and lower risk of heparin-induced thrombocytopenia with low molecular weight heparin. Of course, in our cohort, most of the people received unfractionated heparin. And in general, the decision to start one or the other is very patient-centric. You need to look at things like renal function, whether the patient is hemodynamically stable or unstable, whether there is any scope of receiving systemic thrombolysis or advanced reperfusion. These things might guide, institutionally what anticoagulation started first. But when it comes to timing of initiation of anticoagulation, this is not really well defined in acute PE, and there are no real randomized controlled trials that really look at this particular aspect. The CHEST guidelines themselves in 2012 have stated, they just mention broadly early initiation of vitamin K antagonists, and the reason they mentioned this was, in this group of people in those guidelines, they were already on parenteral anticoagulation, and they recommended starting warfarin early so that bridging would happen early, as opposed to starting it later. But they didn't really specify a particular time as to when anticoagulation should be started. Even the PERT consortium in 2019, they just mentioned that anticoagulation should be started as soon as possible, as soon as PE is diagnosed, but there's no specific time that's mentioned. So the real question is, therefore, what is the benefit of an earlier time to anticoagulation? Like we found in our study, there is I would assume that an earlier time to anticoagulation, in the short term at least, mechanistically may have some benefit because it would relieve pulmonary vascular obstruction quicker and therefore reduce the pulmonary vascular resistance, or the PVR. And this may have a lesser adverse impact on the RV function and contractility in the short term. And in the long term, our study shows that RV function may improve better and further if anticoagulation is initiated early. But of course, this was a retrospective study. We need RCTs to actually look at this impact of early versus delayed anticoagulation on RV function and confirm this. Persistent RV dysfunction, because of background comorbidities or because of residual clot in the pulmonary vasculature, that is considered to be one of the reasons for people suffering from the post-PE syndrome. Again, in this regard, our study included all PERT-managed PE patients. But perhaps in the future, one thing to consider would be to include people specifically with intermediate high or high-risk PE patients, because they would be more likely to benefit from earlier interventions as opposed to patients with low risk in the ESC stratification. So I want to now focus a little bit on the importance of persistent RV dysfunction. What is the importance of having a persistent RV dysfunction? Of course, in the short term, RV dysfunction in an acute setting, it is one of the criteria to consider when you are risk stratifying your patients according to the ESC risk score. And therefore, theoretically, if I can relieve my RV dysfunction earlier, there may be some benefit for the patient in terms of moving them down on the risk score and therefore improving their mortality. But this is only theoretical. There was a meta-analysis that was published in Lancet in 2023, which sort of looked at persistent RV dysfunction in patients with PE on follow-up. And this meta-analysis included about 33 different studies, of which it was a mix of prospective and retrospective studies. And there were about 4 RCTs in this analysis. And the parameters that they looked at were TAPSE, or the tricuspid annulus plane systolic excursion, the RV to LV ratio, and the pulmonary artery systolic pressure. And I think they emphasized on these 3 parameters a lot, because these parameters actually talk about RV contractility, morphological change in pressure load on the right ventricle. So this paper suggested that in the long term, RV dysfunction, if you look at actually patients who diagnosed with PE who then follow up in the clinic, in the post-PE spectrum of things, RV dysfunction is actually much higher in prevalence than full-blown chronic thromboembolic pulmonary hypertension. And patients with a higher RV to LV ratio, a lower TAPSE, and a lower right ventricular free wall strain at discharge were more likely to develop post-PE impairment at 6 months. And post-PE impairment is defined as persistent shortness of breath, dyspnea on exertion, functional limitations, exercise intolerance after 3 months of anticoagulation. So incomplete recovery of the right ventricle, this analysis is suggesting it strongly predicts post-PE impairment or CTEPH. But an actual relationship between persistent RV dysfunction and functional impairment has not really been fully demonstrated. So what are the future prospects? One thing that our research group is interested in looking at is seeing time to intervention, whether that's anticoagulation or receipt of advanced reperfusion therapies. What impact does it have not only on RV function, but on other outcomes of PE, including mortality, readmission, mortality at 1 month, at 3 months, 6 months, 9 months, readmission, other parameters, including functional parameters, quality of life indices. These things, very few studies have actually looked at it. There have been observational studies in the past that have suggested that time to anticoagulation may influence outcome, but the results are conflicting. So there was a very small study back in 1987 which showed a shorter length of stay in patients who started on warfarin therapy earlier. And that's probably because bridging anticoagulation duration was shorter, but there was no change in mortality. There were 2 recent observational studies, one in 2010 and one published last year, which suggested a lower mortality in patients who received early anticoagulation. And there was one observational study in 2019 which showed no change in mortality. So the results are very conflicting. And in terms of studies looking at time to advanced reperfusion therapies and outcomes, there are a handful of papers that I've actually been able to find. One paper that our team recently published in Annals was we looked at different PE metrics in which we mention an arrival to procedure time, and our arrival to procedure time was about 10.9 hours, but we didn't really look at the
1 more minute so we can go for questions.
Yeah, we didn't really look at the association between this time to intervention and other outcomes. And even other studies have mentioned the time to intervention, early being less than 24 to 48 hours or late being more than 24 to 48 hours. And recently there was a study published in Circulation which looked at early intervention being less than 12 hours. So this is something that we want to consider doing and looking at going forward. Of course, our study was not without limitations. Different anticoagulants have different onsets of action, and institutionally, we usually start anticoagulation as soon as possible. Some delays may have been there because of transport, because of port chat discussions, etc. And obviously, ours was a retrospective, non-randomized study. Look, there are different confounders that we could not account for, including when the actual onset of symptoms were for the patient before they came to the ER, when the echo was done. Though we did propensity score matching, to consider these confounders, really a prospective randomized control trial is what is needed to account for all these confounders, because they would have strict inclusion and exclusion criteria. And obviously, another bias that we have is we only included patients who actually survived the PE diagnosis and were able to follow up outpatient and get a follow-up echo. Those who died earlier were not captured, understandably, and that may have skewed our sample. And other studies suggest that more than RV to LV ratio and TAPSE and PASP, looking at the myocardial performance index and global longitudinal strain, these are actually more objective parameters which are less dependent on observers' interpretation of the echo. So that observer variability was not accounted for. But that being said, I do think that our study is is a start to something that can be considered for the future. So in conclusion, early anticoagulation had better improvement in RV function on follow-up as suggested by a small retrospective study. Thank you once again for the opportunity to present here today. And these are my references.
That was really great, Dr. Sridhar. In the sake of time, we're going to move to the next presentation. Dr. Koehler, if you could share your slides.
My name is Zach Koehler. I am a third-year pulmonary critical care fellow at IU School of Medicine, and I am going to be talking about the study I started actually back when I was still a resident. So briefly, the reason this is important is overall, depending on the studies you look at, there's suspected to be roughly a 1% prevalence of pulmonary hypertension worldwide. And this includes all groups of pulmonary hypertension, obviously group 2 being the most common. But regardless, this is roughly 70 to 80 million people worldwide. And this not only impacts their quality of life, but also has a pretty significant financial impact. Some of these studies, just for group 1 alone, predict that itself is about $3 billion or more a year. And despite this prevalence worldwide, we still don't have a lot of therapies to fall back on outside of what's available for relatively our small subgroup of group 1. And so this actually came about from a prior study. So this was a study done a couple of years ago by Tim Lam and colleagues within the VA system here. And they did this study looking at RAS inhibition and the impact on mortality in pulmonary hypertension. And the reason they decided to do this is because prior animal studies had actually shown some attenuation of pulmonary hypertension when the RAS system was actually inhibited. So in their study, they actually looked at ACE inhibitors, ARBs, as well as aldosterone antagonists. And they included all groups of pulmonary hypertension. And what they found was that the use of ACE inhibitors and ARBs, they actually saw a mortality benefit in patients, but they didn't specifically look at all of the subgroups. And so our question was, do the mortality benefits associated with ACE inhibitors and ARBs extend to specifically group 3 pulmonary hypertension? And so what we did was, this was a retrospective analysis. We utilized data from our organ transplant database here, as well as our electronic medical record. And we looked at hemodynamically confirmed group 3 pulmonary hypertension patients. When this data was collected, the definition was still using the PA mean of 25, but we actually included people down to 20 in our groups. And we were comparing mortality between those who were on ACE inhibitors or ARBs versus those who were not. And these were all patients who had eventually undergone lung transplant. To make up for some differences in tobacco use, we actually used propensity score matching to help eliminate and address that confounder. And then we ended up with a data set of just over 200 people with equal number of individuals in each group. And so here is just a little bit of the statistical analysis as far as what we did with our categorical variables, as well as our continuous variables. Ultimately, since we utilized propensity score matching, the survival analysis, we used Cox proportional hazards model. And so here's a look at the demographics between the two groups. And ultimately, there was not any big difference. Most of these groups were pretty similar across the board, at least as far as demographics. I will say it was a majority of white males, but it was similar between both the users and non-users. And then once we did the propensity score matching, we had similar rates of alcohol and tobacco use. And so here is a table, and I apologize if it's a little small. This is actually looking at some of the hemodynamic characteristics. So some of our right heart cath data, looking at some of our PFT data. And again, similar to our patient demographics, there were no real substantial differences in any of these characteristics between either group. And so ultimately, what we found was that individuals with group 3 pulmonary hypertension, the users, you can see there, this red line on top, they actually had a survival benefit over time, which as time went on, it seemed like there was an increasing difference between the groups. And when we looked at our actual hazard ratio between the two, we came up with a hazard ratio of 0.45, which was statistically significant. And so based off of this study, we were able to conclude that the use of ACE inhibitors or ARBs was associated with a lower mortality in group 3 pulmonary hypertension patients, at least those who had undergone lung transplant. And it helped confirm some of those results seen earlier by Lam and colleagues that there was a mortality benefit overall in patients utilizing either one of these medications. So it brings about whether ACE inhibitors or ARBs may represent a potential treatment option for patients with pulmonary hypertension, including group 3. Obviously, further research is needed to see if there are similar results in patients who had not undergone lung transplant, as well as some of the other groups. I think one of the important things here, too, is some of the limitations as far as our study is it didn't necessarily take into account some of the unmeasured confounders. So again, these were people who underwent lung transplant. So at least here at our program, these patients undergo pretty extensive lifestyle modifications as far as aggressive physical therapy, dietitians. They're frequently followed. It didn't specifically, it looked at all-cause mortality, so it didn't specifically look at specific causes of mortality. We didn't look at cumulative dose of ACE inhibitor ARB use. So these were at least patients who were on the medications up until the time of their transplant. Most of them were on it afterwards, but the time that they were on the specific medication we did not take into account. And with that, that is what I have. I'd like to acknowledge the individuals who helped with this project, and I can take any questions.
Thank you, Zach. That was really great, and congratulations to you and to Roberto on this project. Sandeep, Adriano, any comments?
Oh, thanks, Zach, and thanks, Roberto. I have one question for Zach. First is why you chose this cohort of patients, those who were, I'm assuming these are listed for transplant and all, because so when we look at the pH data, the mortality or transplant, they are sort of equated. And in these patients, that has already happened, right? So when you're looking at these data, the terminal event has already happened in this cohort of patient. So I think for me to really be convinced with your findings, I would like to see something more to sort of support that the ACE or ARB blockade really changed something. Either you show me this, that those who were ACE and R, who were treated with ACE and R for a certain period of time, transplant was delayed in these patients, or they lived longer, or median age was more, or something, some of those characteristics, versus those where it was not used. Because then I could sort of assume that because the worst event in this whole cohort, the bad event has already occurred. They all are transplanted now, right? Do you understand what I'm trying to say? So I need to see some of those, either demographic difference and all, and plus the patient population itself was not very clearly defined. You mentioned group 3 pH, but I don't know what exactly that group 3 pH is, whether these are ILD pH, these are COPD, what kind of phenotype we are looking at, because all of them carry different meaning in terms of if we are just looking from the pulmonary hypertension perspective. So perhaps when you are looking at writing your paper or manuscript, I would suggest to kind of look into these factors. And one of my other challenge with this was the methodology of propensity score matching, because 100 patient was not really, I think this was the same comment for the previous analysis also. It's not that big of a cohort. So many of these other variables which you try to match become very significant in a smaller cohort. If it's like thousands of patients, it's probably a different, that you could easily nullify those effects, but in a smaller cohort probably would make more significant. These are my general comments, but great, it's novel for sure. Thank you.
I have a question about if you guys also look at spironolactone as an aldosterone blocker.
We did not in this follow-up. In the original study that they did in that VA cohort, they actually did look at them, and they did not see a mortality benefit with use.
Mm-hmm. And how do you think it works, the ACE inhibitor, in improving survival? Is it working on the RV, or have you looked into RV function, whether it changes or something extra that could explain the mechanism of action?
Yeah, so this was actually one of the big questions and big topics of discussion at the conference, as well, as far as what the actual mechanism would be to explain survival benefit, at least if it was due to the medications. So not really sure if there's an impact on remodeling, not sure if this has to do with volume status. I'm not really sure.
There is a comment in the chat box for you, Zach. Was there any difference in the underlying lung disease diagnosis between users and non-users? That is COPD versus IPF versus other ILD, and how about the pulmonary vasodilator use?
So as far as pulmonary vasodilator, there was not any, I didn't include it in here, but there was no real significant difference between other medications between the two groups, or comorbidities in general. I will say we didn't specifically, I'd have to go back and look at the data as far as how many had COPD versus how many had things like sarcoid or ILD, or IPF and some of that stuff.
Thank you so much, Zach. We're going to move to our next presentation. Samantha, if you could share the slides of Dr. Raza. There we go.
Okay, thank you so much, Samantha. Hi, everyone. My name is Ahmad Raza. I'm one of the third-year fellows at Temple University Hospital in Philadelphia. And my mentor is Dr. Gayan, who's graciously joined us today. Next, please. So no funding or affiliations to disclose. Next. So our study title is the difference in survival between different phenotypes of patients with coexisting COPD and pulmonary hypertension. So basically looking at the part of group 3 pulmonary hypertension, specifically about COPD patients. So a little bit of background. I think it's pulmonary hypertension it has been quite relevant in patients with COPD as it affects their quality of life. It poses high morbidity burden when it is present, especially when we are talking about moderate or severe pulmonary hypertension. And also, it has shown to worsen the mortality in patients with COPD. The prevalence has been all over the place depending on what severity of pulmonary hypertension you're talking about. It can be somewhere about 30 to 50% when you're talking about the mild pulmonary hypertension in patients with more advanced end-stage lung disease due to COPD. Or it can be less than 10% if you're talking about the severe pulmonary hypertension that is solely attributed to group 3 caused by COPD again. So the severity of PH has been shown over and over again that it portrays worse survival in patients with COPD. And the 1-year survival in one study has been reported to be around 70% if you have severe COPD PH, and 3-year survival is about 33%. So 1 in 3 patient dies, while which is significantly worse than 83%, 55% in 1 or 3 year survival in patients with no PH or mild pulmonary hypertension. Next. So there has been a lot of papers looking into COPD and pulmonary hypertension combination. This one I picked because this figure or diagram, it just shows the basic methodology, mechanism, and implications of pH in patients with COPD. It is a paper from 2014, 2015. And even before that, like in late 2000s, there has been a lot of talk about various COPD and pH phenotypes. And as you can see in this diagram, that it's a spectrum of disease, where on the right spectrum there is COPD without pH, and on the far left spectrum there are patients who have solely pulmonary arterial hypertension with some coexisting COPD. But the in-between area is not very well defined. At least in that paper, it was thought to be there is a pulmonary vascular phenotype, which is closer to PAH compared to patients who have COPD. And because of their emphysematous destruction and alveolar and capillary loss, these patients end up developing mild form of pulmonary hypertension. And the mechanism of both these kind of pH from spectrum to spectrum, it also varies. And this question was mostly raised because those patients, a lot of trials on COPD and pulmonary hypertension, they have really mixed results in the past. And if you review that patient population who those trials were done, they did not really directed the patient population, the selected patient population did not belong to one phenotype. It was more of a mix group of patients with COPD who happen to have pulmonary hypertension. They did not define it by the severity of it, how severe the COPD was, and how severe the pH component was. So that's why the mixed results, both on the ends of intervention from pulmonary vasodilator treatment, and the conclusion is that we do not have any approved treatment for patients with COPD and pulmonary hypertension. Next, please. So we talked about it a little bit, that why is it clinically relevant that patients with COPD PH, why do they must have COPD phenotype? How will that help them? So as I said, they have a different clinical progression and natural history. Patients who has mild or no pulmonary hypertension, despite the fact that they have COPD, which may be mild, moderate, or advanced, their trajectory is going to be different in patients compared to the patients who has pulmonary hypertension. Their hemodynamic profile is different. Their radiographic profile is different. They have differed morbidity and mortality. Obviously, with this paper, we're going to shed more light on mortality and the potential for the tailored treatment based on the predominant phenotype. Because we theorize that if the patient has a lot of vacuum mismatch and the patient has a lot of emphysematous destruction with only mild to moderate pH, that patient is not going to do well with the pulmonary vasodilator treatment compared to a PAH patient or pulmonary vascular phenotype patient. Next, please. So the methodology was pretty straightforward. It's a retrospective cohort study of all the COPD PH patients that we managed at Temple University Hospital. It spanned from 2010 to 2021. We are lucky to have a lot of end-stage lung disease patients and COPD patients. A lot of them are referral for the COPD treatment, for the valve treatments, and also because we do a lot of transplants in such patient population. So we were lucky to have such a generous cohort of these patients. So what we did, and this is probably one of the most important part of the presentation, is that we separated them into three phenotypes: pulmonary vascular phenotype, parenchymal phenotype, and mixed phenotype. And this was not really random. It was based on the newer guidelines from ERS, ESC, that we now define the severity of pulmonary hypertension based on the pulmonary vascular resistance rather than mean pulmonary arterial pressure. So we took that cutoff of PVR of more than 5, and we used the cutoff of FEV1 just to characterize the severity of airflow obstruction, which translates into how bad the COPD was, and then use that combination to create these phenotypes, where the first group with the pulmonary vascular involvement, they're going to have more pulmonary vascular resistance, more than 5, and their FEV1 is not that bad. It is more than 50% predicted. Compared to the last group, is the predominant parenchymal phenotype, which is exactly opposite. They have severe airflow obstruction, their end-stage COPD, but their PVR was less than 5, which is in predominant number of patients that we see with COPD and pulmonary hypertension. And obviously, the primary outcome was death before the potential lung transplant. Next, please. So this is just the diagram of how those phenotypes were created. Some of it is obviously a novel work. There are no guidelines to create how do we actually create the phenotypes. How there are suggestions, as I discussed with one of the papers that I reviewed earlier, that some of the patients behave more, that they have more vascular problem than parenchymal problem, and compared to some patients who have opposite. So as you can see, the FEV1 was predicted. It was not bad. It was a moderate to high FEV1, or actually moderate reduction at best in FEV1 in PAH phenotype. While if you correlate that with the pulmonary vascular resistance, their pulmonary vascular resistance was almost always for all the patients for more than 8. And quite opposite spectrum was parenchymal phenotype with severe airflow obstruction, but not so much pulmonary vascular resistance. And the mixed phenotype kind of somewhere in between these two. Next, please. So we had about 480 patients with COPD and pulmonary hypertension. We excluded about 111 patients due to group 2 pulmonary hypertension, and that was based on echocardiogram, evidence of systolic or diastolic dysfunction, their diagnosis of diastolic dysfunction, and their pulmonary capillary wedge pressure. If it was more than 15, they were excluded. 53 patients had evidence of both fibrosis and emphysema. They were excluded to have a clean cohort of patients with no confounders. So we ended up with 316 patients. And the distribution was kind of what we see in the previous studies, that a lot of those patients are going to have mild pulmonary hypertension. We call them pulmonary parenchymal phenotype. The least number of patients had pulmonary vascular phenotype. About 30 of them we gathered in our group, and 61 had mixed phenotype. Next, please. So in results, we found that most patients, obviously, as we discussed, belong to pulmonary parenchymal phenotype, which what you expect in a COPD PH cohort. The mean PVR in the pulmonary vascular phenotype was 9.5 Woods unit, compared to 8.7, very close, a little bit less in mixed phenotype, and 2.87 Woods unit in a pulmonary parenchymal phenotype. So they're still technically, by definition, they have pulmonary hypertension, but not as severe as the other two groups. And when looked at the FEV1 predicted for the above phenotypes, the vascular phenotype has it about mean of 67.4, compared to 35.8 and 22.3 in patients with mixed and pulmonary parenchymal phenotype. So this is a summary of findings that the pertinent ones, at least for all of these three phenotypes, their ages were pretty comparable. Obviously, least amount of patients in PAH group. And if you focus on the mean pulmonary artery pressure in these patients, the highest mean pulmonary artery pressure was in the group for PAH phenotype. It's 44.3 compared to 25.9 in parenchymal phenotype and 39.5 in mixed phenotype. And if you look at their mean PVR, we talked about it a little bit in the previous slide, it was 9.5 in PAH phenotype compared to 2.8 in parenchymal phenotype. And in mixed phenotype, it was somewhere in between 8.7, more towards the PAH type. And obviously, their DLCO were quite low for all of these patients. Next, please. So in our study, what we found is that there are 16.7% patient died in pulmonary vascular group before potential lung transplant, while close to double patient died in mixed pulmonary vascular group, pulmonary vascular and parenchymal group, and 11.5 patient died in patients with pulmonary parenchymal group. And the Kaplan-Meier survival analysis showed different survival probabilities among the three phenotypes. Obviously, mixed phenotype, where patients had severe emphysema and severe pulmonary hypertension, they had the lowest survival probabilities. And Cox regression model showed that compared to the parenchymal and vascular phenotype, the mixed phenotype was significantly associated with increased risk of mortality, a hazard ratio of 2.12. Next, please. So this is the Kaplan-Meier curve for all three phenotypes, and the red or purple one that we are seeing at the lowest one is the mixed phenotype here, and that's followed by the parenchymal phenotype and the vascular phenotype, and it just shows that these patients with mixed phenotype and you can theorize why would that be. And I can think of a number of reasons that these patients, they are a mixed bag of severe diseases. They have severe spectrum of disease, both parenchymal and pulmonary vascular. And two, while many physicians may feel confident putting patients who have a PVR of 10 on some sort of pulmonary vasodilator treatment, they may do better. And the patients who have pulmonary parenchymal disease with PVR of 2.8, their guidelines are kind of clear that we don't put them on pulmonary vasodilator treatment because they may have pulmonary parenchymal process that's driving it. But the mixed phenotype group is really hard to deal with, to identify and then address. The patients with moderate to severe airflow obstruction with PVR of 5 or 6, not a lot of individuals, the physicians and the person taking care of them are going to feel confident putting that patient on the pulmonary vasodilator treatment. So that's one of them, and it's the least well-defined amongst the three defined phenotypes that we have. Next, please. So the major takeaway or the conclusion from this was the patients with PH have distinct phenotypes, unique clinical characteristics, hemodynamic profile, as we alluded to in our table, and the risk of mortality without lung transplant. But these patients, these can't be put together, and their survival for mixed pulmonary vascular and parenchymal phenotype is worse compared to if they have one or the other. Because again, one theory, in my mind at least, is that because we have more guidelines to deal with those kind of patients. Next, please. So where would we go from there? There should be a need for, and there is need for, universally acceptable definition of COPD-PH phenotypes. And you can call it, one of the limitations of this study is that we are making it up actually about these phenotypes. We do not know, there are no guidelines from anywhere how to phenotype them. There is a lot of data out there that these phenotypes exist, but it is more of a person dependent how they put one patient in one or the other category. How it would help is there needs to be prospective studies looking at individual treatment plans for such patients based on predominant phenotype, and then exploring the roles of pulmonary vasodilator treatment for all pulmonary vascular, and select mixed phenotype patients. to see if we direct those phenotype patients with the pulmonary vasodilator group, there may be some benefit to those patients. I did not discuss.
Yeah, thank you, Dr. Raza. Any questions, Adriano, Sandeep, you can put it on the chat box.
Hi everyone, my name is Breanne McCarthy. I'm a current third-year pulmonary and critical care fellow at Penn. I'm excited to be presenting our work today. So as many of you know, PH medications are very costly for patients, and insurance coverage and restrictions such as step therapy and formulary limits vary widely in the United States. Prior work has found that although most patients with PH have insurance, many still report significant financial burden, resulting in reduced medication adherence and a need to change to alternative regimens. Coverage barriers may lead to delayed or suboptimal care, potentially contributing to disparities. We hypothesize that PAH medication use would differ by insurance type and be associated with worse clinical and patient-centered outcomes. This was a prospective cohort study of incident adult patients with PAH enrolled in the Pulmonary Hypertension Association Registry, or FAR, from 2015 to 2025. The FAR is a multi-center longitudinal registry of patients across the U.S. who receive care at PAH-accredited centers. Exclusion criteria for our study included patients with portopulmonary hypertension, CTEPH, and PVOD, as well as patients who were uninsured or had unknown insurance type, because we had a few numbers of patients in these groups. Our exposure was baseline insurance type, classified into one of three groups: private insurance, Medicare, or Medicaid, or similar programs. We found that there is a significant difference in all baseline covariates across the three insurance groups. Medicare patients were oldest, with a median age of around 70 compared to 50 years old for the other two groups. Idiopathic and heritable PAH was the most common etiology across all groups. Drug and toxin-associated PAH was, interestingly, the most common etiology in Medicaid, accounting for about a third of all PAH diagnoses in Medicaid, while it was very uncommon of a diagnosis for the other two groups. Medicaid patients were the youngest, most racially and ethnically diverse, and had the lowest income and lowest proportion of college-educated students. Baseline clinical characteristics also differed significantly across the three insurance groups, with patients with Medicare or Medicaid being more often classified as WHO functional class 3 or 4. Patients with Medicare also had a significantly worse 6-minute walk distance and were most likely to be high risk by Reveal classification. However, interestingly, they had overall better hemodynamics. And then at baseline, Medicaid patients had the worst quality of life scores. To be a little quick for this part, basically, we saw some significant regional differences in insurance status. And then, more importantly, we did see significant differences in the use of PH assistance programs to pay for PH therapy. The highest use was among patients with Medicare or private insurance, while the lowest rates were in patients with Medicaid. We theorize that this may occur because Medicaid drug programs cover medications at no cost or nominal cost to patients. So this may indicate that patients who were able to receive drug coverage through their state Medicaid plan did not then need external copay support. There are also differences in eligibility for the patient assistance programs, with pharmaceutical programs specifically excluding patients with government-run insurance. At the time of the first follow-up, majority of patients were receiving combination therapy, although that was less common in those with Medicare. And for some results, so we found that patients who have private insurance and Medicaid are more likely to receive more intensive PH therapy than are patients who have Medicare, although this did not persist after adjusting for age. Notably, we did find that patients receiving financial assistance to pay for their PAH medications had significantly higher odds of receiving more medications. And in the primary analysis, we had classified patients who had dual eligibility for both Medicare and Medicaid into a single Medicaid group. We performed a sensitivity analysis, pulling out these 48 patients with dual eligibility status and had the same findings, so no difference across insurance type. We next studied participants who entered the registry on 0 or 1 medication to see if there'd be differences in the time to initiation of combination therapy with either 2 or 3 drugs. And we found there was no difference in this time to combination therapy across insurance types. But we did find in a multivariate Cox proportional hazard regression that those receiving PH medication assistance had a significantly shorter time to initiating combination therapy. And for clinical outcomes, we found overall there are no significant differences in ED visit or hospitalization rates, and no significant difference in any of the 3 health-related quality of life scores by insurance. So some of the limitations of our study include a lack of generalizability to the entire PH population, because we're only able to study patients who are receiving care and established care at a PH care center. This population may have more support accessing financial assistance and navigating coverage barriers. Other limitations include heterogeneity of insurance plans and medication coverage, and we also did not have enough patients with military insurance or uninsured status to study these patients. So overall, in this multi-center study of over 1,000 incident adult PAH patients receiving care in an accredited center, we found no significant differences in PH medication use or in clinical outcomes based on insurance type. We did find significant treatment differences for patients who were receiving medication assistance for their medications, with patients having both a higher odds of receiving more medications and also starting combination therapy sooner. Age was likely the primary driver of treatment differences across insurance groups, with older patients being more likely to have Medicare, as well as being more likely to have fewer medications and a slower time to initiation of therapy. Overall, our study showed that patients who are receiving care at accredited PH care centers were able to receive guideline-directed care regardless of their insurance type or household income. PH medication assistance programs significantly impacted treatment access, and we believe that this is really important and that there should be efforts by the PH community and medical societies to ensure equitable access to these programs for all patients. And future work should also explore the impact of insurance coverage in other settings, so there may be greater barriers to medication access outside of well-resourced specialty centers. Here are my acknowledgements. Thank you so much.
Thank you, Breanne, and congratulations to you and to Nadine. Beautiful, beautiful job. A couple of questions for you, Breanne. Why do you think, before you adjust for age, why do you think Medicare patients were less likely to receive more medications? What are your thoughts?
So I think in this country, Medicare patients are generally age 65 and older, and we saw that with how much older the Medicare group was. So I think this is actually representing a guideline concordant care for these patients. As the guidelines state, we should be more cautious with elderly patients and more cautious with patients with more comorbidities. So likely this group of patients, as we see after adjusting, they're before are taking longer to be started on combination therapy. If they're started on combination therapy, they're less likely to receive more medications. And we think that really is an age effect more than anything.
Yeah, and it's also possible because of age, they also have more comorbidities, and maybe that's part of the reason they are getting treatment with monotherapy or so. And how did you define poverty on your cohort?
So I indexed to the federal poverty limit and specifically looked at household income size. And the US updates every year with the federal poverty limit. And I indexed it to the poverty limit at the time when they were enrolled into the FAR.
Very great. I think we have time for one more question. Adriano, you have a question for Breanne?
Yeah, I was thinking in the supplemental insurance for Medicare patients, whether that had an impact or not.
Fortunately, we do not have that granularity in this data set. We really just knew if someone was on Medicare, Medicaid, or had private insurance, military insurance. It would be interesting to look at in more of a claims-based database, but in the FAR, we do not capture that information.
The same with the annual income, because I think the more money you make, the more copays you pay. And then it's against patients getting the medication, because even if you make a good amount of money, in retirement, you don't want to pay $500 of copays, and that certainly delays things.
Well, Breanne, congratulations again. Hopefully we will see your manuscript soon. And Priyanka, Ahmad, Zach, and Breanne, thank you for joining us. Adriano, Sandeep, Maidah, thank you for joining us. All of you enjoy the rest of your day, okay?
Thank you.
So much.
Thank you, everyone. Great job.
Thank you.
Bye-bye.